So if for someone who was not getting a transplant, they would sooner need another treatment, or they would sooner develop some side effects than if they got a transplant. These were randomized studies done for patients who got a transplant early in the evolution of early after the diagnosis of multiple myeloma. And again, I have to mention the caveat: these are clinical trials, highly selected individuals. They were limited by age, they were limited by closeness to a transplant center, they were limited by having to accept to undergo a randomized study, and they were selected for organ function. They had to have good kidney function, good lung function, they had to be able to afford it or have insurance that could afford it, and so on. So this may not apply necessarily to everybody, but these are the lessons we learn from the clinical trials of transplant in multiple myeloma. We talked a little bit about how it's done. I'm actually going to skip this slide for that reason. This just to introduce again some of the terms we used, that the mobilization referred to the ability to collect the stem cells from the bloodstream and then to separate them out, preserve them by freezing, and give them back. Remember, as I said, melphalan is a drug that is used to create the destruction of marrow before you give the stem cells back. So a transplant side effects are really, in large part, the side effects that come from getting a high dose of melphalan, which is a chemotherapy drug. So it unfortunately comes with the side effects that we usually expect from chemotherapy. They include some nausea for a variable period of time. Nowadays we can help most of the nausea, but not all of it. It includes sometimes having to be hospitalized in order to get transfusions or antibiotics, or sometimes if patients develop mouth sores and cannot eat or drink well, they might need to be hospitalized in order to get IV fluids or intravenous nutrition. Some patients have to be hospitalized for other reasons. Maybe they live too far away from the transplant program, because this unfortunately is still a treatment that is not available everywhere. As chemotherapy, it's associated with hair loss, it's associated with some risk of infections, but most of these side effects, practically all, are very finite in time. So the hair will grow back, the stem cells will grow back, the blood counts will recover, the transfusion need will get better, and so on. The nausea will pass. And therefore, transplant has some limitations. Unfortunately, in the majority of patients, it's not going to cure the disease. A true cure for a disease is one that somebody could administer and say, go home, sleep, and don't bother with the disease from here on. Don't ever get tested for it. Don't ever get treated again for it. In reality, none of the treatments we have for myeloma at this time allow us to be able to say that to a patient. However, they do come close, and there are some subsets of patients whose results after a transplant, or sometimes after other therapies that we're not talking about today, are so close to a cure as to approximate it. For example, about 10% of patients who got an autologous transplant more than 10 years ago have still not relapsed. Are these patients cured? Possibly. We just don't know. We have to keep looking and keep following them. About 20% of patients who got a double autologous transplant, so they got two transplants, the old saying of one good turn deserves another. Well, they said one good transplant deserves another. So if you got a good transplant, very few side effects and so on, and the way it's currently practiced, if you still have some myeloma cells in your marrow about 100 days after, then very often we will recommend a second transplant sometime within the next 3 to 6 months. Many of these patients, 20% of these patients who first had that therapy, and it's going on probably almost 10 years now, about 20 of those patients have still not needed treatment. Some of them you can still detect the disease, and so we know they are not cured. But functionally speaking, they've not needed treatment again, and the disease hasn't bothered them again. And then there are certain subtypes of multiple myeloma you probably heard about this morning, where it can be predicted that a transplant might not be their best treatment. There might be other treatments more suited for them. We talked about the side effects and some of the advantages, the shortness and finiteness of the treatment time, the fact that once you've had a transplant, most patients will then enjoy several months after that of not needing additional myeloma treatment. The survival advantage, the fact that the easiest way to think of this is that it resets the clock. So in somebody who has a certain period of time for their disease to progress, a transplant will often reset the time back so that they have a little bit more time that way. There's full recovery from side effects and very low serious risk like permanent organ damage or something like that. It can also currently be repeated one more time in most individuals, and in fact many transplant programs, when they do a first transplant for a patient, will try to save enough of those stem cells so that if that patient needed another transplant, they could get it easily later on. Perhaps the most exciting part is that a transplant can be combined with other treatments. So patients can soon after a transplant begin to add other treatments, bortezomib, thalidomide, Revlimid, medications like that, or even get them at the time of transplant and so on, again individualized by patient. The insurance coverage for transplants remains generally quite good. Most insured individuals and practically all Medicare age patients can get transplants paid for. It's not as good as we would like it to be, but that's a bigger national debate. This is a graph of patients who received transplants way back in the 90s. So this is from 1996 to 2001. So all the statistics that we can give for a transplant or for any treatment depend on patients who were treated in the past, because we have to have followed them for a period of time in order to see how they are going to do. And this was reported a number of years ago by the CIBMTR, which is a large consortium that reports all transplant outcomes. So many of these transplants were not done as well as they are done nowadays, and I suspect that today's treatments, if we came back and replotted this graph a few years from now, would look better. The way the graph is done is that 100% of patients begin, and every year they count how many patients have not had a major event such as not surviving. And they divided into patients who had had myeloma for more than 18 months before they were treated, and those who got a transplant a little bit early on. So two lessons from this: one, that myeloma still does continue to relapse after transplant, the way transplants were done back then. Secondly, there are still many patients who are out 6 years from the time and still doing well. And thirdly, that at that time it was generally better to get a transplant early on than later on. Many of these, as I said, have changed because by definition, in looking at a graph like this, we are looking at the way the disease was treated a number of years ago.